I'm Erin Boquin. Yay! Yay! I'm a family physician in town. I've been here since 1998. My two lovely daughters are behind you who have experienced most of the surviving with me, as have my good friends. I'm going to talk briefly about my cancer, with an S, cancers, and then we're going to go on to sort of the survival aspects of breast cancer. So in 2003, I was diagnosed with stage 3A. They changed it because of the size of and the area of the metastasis, because it opened up inside the lymph node on my right, and so it was outside of the original organs. So I had treatment for that breast cancer. It was triple negative, and I had radiation to both the breast and the lymph node area. At that time, I didn't have a mastectomy because it was already outside of the breast. And then I had adriamycin, Cytoxan, high-dose Taxotere in a dose-dense schedule. So I don't know if anybody here knows that. That just means I had all three for all treatments. Then I had various side effects, which we'll go over, and then I had, and I had a lumpectomy. And then it looked like it came back about 2 years later, and I had a lobectomy on my right breast. And that just meant that they took more. And at that time, they didn't want to do a mastectomy, I don't know why. And so then in 2014, I had a localized breast cancer. And at that point, it was pretty clear I needed a mastectomy. So I went out to California because I had difficulties with my lungs from the radiation, so I didn't want to be at this altitude. So I had a mastectomy with a tram flap where they took my belly and put it up here. And then I had so much belly that they had to do a reduction. And I'm probably going to be on what's called an aromatase inhibitor, but as we'll see, I just am not ready for that yet. And so this is, so that's just sort of the background of me. I have a family history. I have a very large family on one side and a very small family on the other. My family history is on my dad's side, and my grandmother had postmenopausal, like very localized breast cancer, had a mastectomy. And my great-grandmother had the same cancer, from what we can tell, at the same age that I was at, and when my grandmother was the same age as my youngest. And so that's probably genetic, but the Myriad test showed an uncommon translocation at the beginning that only 200 people that they'd ever checked had, but then afterwards they said it was nothing. The new test, I'm going to be going out next week. I'll probably have a new test done. The fact is we treat it genetic, doesn't make any difference. And so that's the idea, is everybody assumes that I have a genetic breast cancer, and I have two sisters, they haven't had any problems. My mother hasn't had any problems. I have second cousins that have had problems, and I have a second cousin who's a man. So it's pretty clear that it's genetic. You know, the man and he had breast cancer. Okay, so that's me. Let's see if I can do this. Okay. One of the reasons why there are so many more survivors is the treatment of breast cancer has improved, as has identification of early breast cancer. So, and maybe I shouldn't say that there are more survivors, but part of that is because we can diagnose it better. And most of this is what I can attribute my survival to, because I had the chemotherapy regime that I had for the first breast cancer. It was in studies at the time, and Dr. Greenfield at New Mexico Cancer Institute took me off this. I mean, did it off study, but did a current study recipe, and that was the elevation of the taxane dose. And then 5 years afterwards, it showed just a tremendous survival rate. When I was first diagnosed, they said I had 30% chance of 5-year survival, And when this study came out with the recipe that he used on me, it was 70% survival at 5 years. So these new regimens of old chemotherapeutic agents has really made a difference. The dose dense was better than every 3 weeks, which is what I did. You know, I'm like lucky. Not lucky. I had good doctors. I have really good doctors. I've had longer therapy, and I have had friends since then that have benefited from the addition of new chemotherapeutic agents, most notably HER2, Herceptin. And so there's all kinds of things that make it so that we can survive. Now, that being said, sometimes you feel like you would rather not. U.S. Cancer prevalence, there's 10 million cases of cancer currently, and 22% of them are breast. So if by unfortunate chance you're one of those 22%, you're not alone. It's a team, and this is the part that I think is the most difficult, because there's no clear agreement among healthcare professionals on a survivorship definition. I think this is improved, but I go with what that's mine. That's the one that I use. And so anybody who's diagnosed with breast cancer is a survivor for the rest of their life. And this was one that was being used more in 2003, which meant that I didn't feel like I survived until that 5-year party, which is why I had it. It was a very good party. So in any case, which doesn't mean I'm not going to have another party, by the way. But every day is a party. So this is my definition, which is so nicely shared with the National Coalition for Cancer Survivorship. It's the definition that I share with many friends that have had breast cancer. I currently work with a survivor group on a study that's being done through LANL on a new breast cancer identification technology, and we're all on board with that. These are the challenges, and I don't think anybody can, this slideshow is difficult for me to put together because, yes, I've had days lost from work, my general health perception has been less, and sometimes I need help with daily activities, like most of the days. So I have very good family support and very good friend support. This community has been awesome to me. So I've been good, but yeah, first of all, you don't even talk about the health, the direct health costs of somebody like me who's been treated as I've been treated, but the crazy costs of lost days, crazy costs of everything else. And I think, so the 3 seasons of survivorship. The acute is when you're diagnosed, you're still sort of in the stages of grief and loss, and then extended is when you realize, okay, and in my extended period of time is when I decided if it ever happened again, I would go to City of Hope. And I had recurrence anxieties, and they reassured me at City of Hope. It's just a center in California. And I always had those thoughts of returning to normal. But it turns out most people never return to normal, even if they don't have breast cancer. Normal is a very, very elusive thing. And so, it's just the new normal, whatever the new normal is. And then in remission, late side effects of therapy, and long-term risks. It's a little easier for me to feel, I still feel like now I'm here, even though my latest breast cancer was just 6 months ago. Because it was a localized cancer and they fixed it. So even though the surgery and the treatment was really difficult, the concept of remission is a lot easier to wrap my head around. Okay, this is not in general practice. It's one of the reasons I went to City of Hope. And it's basically a sheet that you use to deal with your survivorship. And it makes it very clear cut, just like your chemotherapy did, most people do this in your head, but when I went around to look for the doctor, for my breast, for, you know, where I would get treated, if I had a recurrence, the woman that treats me, Dr. Kruper, this is what she put together for ASCO. And so it basically is, it's who's on first. You know, so I go to my OBGYN for the pelvic exam. Dr. Kruper doesn't do that. And nobody. This is all, you know, so it's a checkbox. It's not anything like a mystery. You know, the genetic testing that Patrick Dawson spoke about, anytime it comes out, I get it. You know, so, and it's all been negative. So, essential components of survivorship care, and again, we live our whole lives now with being survivors. And so, if we can really clarify the fact that this is not something that's happened to us, but it's something that's happening with our engagement, then we want to look at prevention, which I'll talk about, surveillance, which goes up and down. I mean, when we started to be able to do MRIs, the reason I had that second surgery for the recurrence is because MRIs are so sensitive that it looked like I had a recurrence. But even the radiologist didn't believe that it was a recurrence. So it just lit up. You know, sometimes you get too much information on a test. And so the surveillance, so you constantly have to be staying up with, you know, I don't want to have another MRI, ever. Because I got surgery after my last MRI. But there's other ways, especially, you know, this technology that we're working on right now is ultrasonography. There's clearly other ways to do surveillance that we can get better at, that we don't have compression with with mammography. We can go to this a little bit better. Intervention, I think the important thing here is treating the consequence of cancer and its treatments. So sometimes the treatments cause more problems. Like my kids, I hate to point them out, but they don't remember my cancer because it was 48 hours of cancer talk. But the treatments lasted a lifetime. And those the effects of the treatments, late effects of treatments, are constantly working. And this is really, really important, and I think I've been blessed with good coordination of my PCPs and specialists. I picked my PCP when I moved here in 1998, right after medical school, and had never met him. And I had never seen him before I was diagnosed. I wrote my own mammogram order. And not a good thing, and thank God the hospital doesn't let you do that anymore. But now, of course, we're attached to the hip. I have records like this, and he coordinates all of it. So, obviously I'm a big believer in primary care providers. And I'll just tell you, it's Jim Joe. So, yeah. So this is the side effects, and I can tell you, I think I've had every single one of them. I mean, I truly believe, and I think, oh no, I haven't had this one. And I haven't had that one. But you get the idea. And along with the improvements in chemotherapy and treatment options for the cancer, there have been a lot of treatment improvements of side effects, which I think is another reason why survivorship and survival is a reasonable thing. As long as you can keep the depression at bay so that you have hope, then you can always find something that's going to fix you a little bit better. Whether it's ashwagandha, or whether it's holy basil, or whether it's a new massage therapist. There's always something out there that's going to make you feel just a tiny bit better. Musculoskeletal events, these are long-term medical issues, and again, this is the part where I'm a doctor, so I'm postponing the use of my aromatase inhibitors, although, the chance of me having a third breast cancer in my life is not zero. And so I'm going to have to go on this, and it's going to put me through the menopause again. Even though I don't have ovaries. And so the idea is that without estrogen, you're at more risk for osteoporosis, I have lived most of my life in the overweight to obese category, so my risk of osteoporosis is slightly less. I don't have a family history of osteoporosis. This is not going to be the biggest problem I have. But it is a problem in survivors. And it's something, I don't do a lot of bone density tests anymore, but I do them in people that are hormone blocked for a reason. Joint symptoms, this one's a killer. And, and so you have joint symptoms because you're deconditioned, but then you also have joint symptoms because of the tamoxifen. And I've had so many patients that have basically, threatened, negotiated, everything they could possibly do for me to say that they don't need to take the tamoxifen. But the fact is that there's really good evidence that it makes a difference. And so it's hard, it's just hard. So what I do is I generally, as a physician, look to those other things that help, and we'll go into those, with the side effects of the tamoxifen, which is the treatment. And for the, does everybody know what tamoxifen is? For hormone, yeah. Estrogen deprivation, which is basically along the lines of tamoxifen. And also, like, I went into menopause after my first treatment because of the medicines I was taking. And so, and then the tamoxifen, and then all of these things happen along with it. And so these things, again, you can't negotiate the chemotherapy and you can't negotiate including the tamoxifen, but you can be hopeful that there is an answer for the side effect because you just keep trying. I can't tell you how many times I've walked into Pharmaca and said, what do you have for hot flashes? And this is what they have for hot flashes. So this line is, so this side is percent reduction in the mean. This side is weeks following treatment. So if you're on tamoxifen, you're in one happy 5-year week, because you're always on it. And placebo is up here, so that means that there's no reduction. Soy, which I've had patients that have been successful with a half a gallon of soy milk a day. Vitamin E, I've never seen that be successful. Clonidine, it's been a miracle to some patients. Fluoxetine is sort of my go-to because they had used it for PMS back in the day when it was when it was brand medication. And so I think that there's something we don't know about fluoxetine and hormone receptors. And then this is Effexor. Yeah, I've seen that work. This I don't use because it seems a little bit intense. But I would imagine that oncologists do. So I send somebody to an oncologist that they need megestrol. Because my bigger concern. There's something that's not showing up here. So this is gabapentin. So gabapentin is Neurontin. And so this is baseline. And this is 300 milligrams of gabapentin and 600 milligrams of gabapentin. So gabapentin works nicely. And especially if you have a neuropathy from the chemotherapy and your tamoxifen. Oh, there we go. I just did not have that. Oh, 900. Estrogen deprivation, sexual dysfunction symptoms. I figured towards the end of the talk we could get down to these issues. First of all, back at the beginning, if you can deal with the depression and maintain hopefulness, then you can really look for solutions to the other problems. And what I see happening is that sexual dysfunction symptoms oftentimes contribute to other problems like personal identity, depression, and so it's not something that we shouldn't talk about, if that makes sense. And it usually, let me just say, I have really enjoyed these conversations with my patients. And the fact is that there's oftentimes some way to get through that. Because again, even if you never had breast cancer, and you have 3 small children, not 3 small children, but 5 small children, 2 small children, there's issues as you go through any hormonal shifts. And so, it's just something I think should be talked about. So this is to review Potential impact of lifestyle factors on survivorship. I can include a bunch of slides on diet and weight, but there's a correlation between insulin levels and success of chemotherapy in breast cancer. So if you have high insulin levels, it contributes to both your increased risk of breast cancer and the effectiveness of treatment. And it's very, very difficult to measure insulin levels. And so, because it's a fragile marker, and so it can waver all over the place. If you get an insulin level, a fast insulin level back at 40, you've got high insulin. But if you get one back at 17, you might just have been eating well that previous week. So it fluctuates, not like, you know. So these are the things that make an impact. This one is talked about a lot, and I think that it's the type of fats. Dr. Lockfield, our biochemistry professor in medical school, came up to me in 1996 and told me that. He just walked up to me. He walked up to me and he said, "What if the fats that cause breast cancer are the bad fats? Sorry, the good fats?" Yeah, I mean, and so I haven't found that in any good literature, but I believe him. So it's low-fat diet is right for everybody. So exercise, I've been terrible at this, but it's very, very important. Limited alcohol consumption is recommended by. Okay, so first of all, this is a really small group. So this is the National Comprehensive Cancer Network Breast Cancer Risk Reduction Study. And so yes, limited alcohol consumption is recommended by this study to promote a healthy lifestyle. Everybody. And so this is, but like I think I can tell you that when I got diagnosed again, I'm calling my friends and I'm like, oh my God, it's because I drank alcohol. And everybody said, no, it's because you don't have a drink in your hand right now.
Those are some good friends.
Those are some good friends. But the idea is that you sort of have to, these kind of things that you hear in the media and you see in stuff, you really have to think about it. You have to integrate it. But it's still, in my opinion, not as important as maintaining strong social relationships, keeping depression at bay, remaining hopeful about other treatments that you can do for side effects and prevention, and maintain this as sort of a skeleton or a Christmas tree that you hang everything else on. Because if you're so anxious about not exercising enough to keep your breast cancer away or prevent breast cancer, then you're not living a full life. So let's go back. Factors associated with reduction in breast cancer mortality. Now this is not reduction in breast, because this is a survivor talk. This is not a reduction in breast cancer. So early detection, currently with mammography, but I'm hoping someday that it will be with ultrasound. If you catch the breast cancers early, then mortality decreases. Adjuvant systemic therapy, hormone therapy, and chemotherapy. You need to do your own homework, and you need to be able to say what you can and can't do as far as treatment. Pick your doctors appropriately, meaning that don't start questioning halfway through. It's like getting off midway on a roller coaster. You need to be able to say, okay, this is what I'm doing. Treatment of advanced disease, hormone therapy, and chemotherapy, and that basically just means, like I've had friends and patients that have lived 25 years with some of the new treatments, and so that is a reduction in the mortality because they die of something else, even though they had advanced disease, and that's mostly along the line of the physiology of cancer in bone. That's all the stuff that we always have done. And that's it. I should have put a picture, but I didn't. But does anybody have any questions? I mean, no, I mean the picture of like my family or something like that.
I thought we-
Yeah, exactly. No, I think this dress is as close as we're going to get to the picture of my surgery. So, does anybody have any questions? Really?
So for tamoxifen, it used to be like 5 years and now it's going to 10?
Yeah. And the reason for that is that, and there's different thoughts on it, but the reason for that is there were a lot of people that were diagnosed with breast cancer at 6 years. And, you know, I mean, like I said, there's all this negotiation, like, can I stop now? Can I stop 3 days ago? Because it's not easy. And so I think now that everybody is, the support systems are more in place for the tamoxifen side effects. And you know, not that they, but it is better to be on it for a while.
Is it easier on the tamoxifen if premenopausal or postmenopausal?
It's very hard when you're premenopausal because you go into menopause abruptly. I don't think it's easy anytime. And you know, you have estrogen stores outside of your ovaries. And so if you have, I mean, yeah, that's right. So that's why I'm sort of waiting on that. In addition, my second breast cancer, although my second breast cancer was a new breast cancer. It wasn't the old breast cancer came back. It was a new breast cancer. So it had a tiny bit of hormone receptor, whereas the first one didn't. So I need to take something like that. And so I know I need to take it.
Have you seen that new, and I can't remember the name of it, the new serum for vaginal dryness, which is negative on the breast?
No.
Because I think it's...
I tell everybody to use shea butter from Farmer's Market.
Right, shea butter. No, because there's a new serum, I wish I could remember the name, but that's out that I think will be able to be used in breast cancer survivors for vaginal dryness.
Oh, good.
It's a pill.
And especially
And it's
for
negative on the breast.
tamoxifen, yeah.
Yeah.
It's a big issue.
But of course, they're not testing in the breast cancer survivors.
But, did you have a question?
I did. A lot of this is just going over my head. I'm losing LR, XAT. I don't even
Oh,
know.
and that's why I didn't,
Yeah.
it's radiation therapy.
Okay, yeah.
Yeah.
Erin, how many of the breast cancers are occurring in women who have no family history of breast cancer as a woman? Do you know that number?
No, I don't know the number, and I wouldn't trust it anyway, because like when I was diagnosed, I didn't know I had a family history of breast cancer. And so, yeah, it's just, I think the numbers I've seen are between 50 and 70%. So more women are diagnosed with breast cancer that don't have a family history. But it's very difficult to, like I know my whole family history on the big family side, but the little family side, they didn't talk about, you know, Midwestern didn't talk about the breast cancers. I mean, since then I went to, well, this is not the answer to your question, but since then, my great-grandmother's experience with breast cancer in the 20s was remarkable. She had a mastectomy done at Cleveland Clinic in 1910, and then she died during surgery at Johns Hopkins for brain mets. And it does look like that was 2 separate cancers also. So and so I went out to Johns Hopkins and looked at the op report and everything. Yeah, so cool. And so, and so, I don't think they talked about it. I don't think they kept records. I mean, she was. That's right. Yeah, I know, you know, and she was 40 years old when she was diagnosed, and she lived to be 54. So her second breast cancer was probably the same time as my second breast cancer. So, yeah.
When's the book coming out?
You know, I have to wait until retirement.
Oh, seriously?
Yeah, but my dad's a urologist, and there's some connections between prostate, ovarian, I mean, there are BRCA genes, melanoma, and so looking at sort of the history of the surgeries and treatments involved in both prostate and breast. They've been sort of a competitive cancers, you know, dueling cancers, but they have so much in common, including the families that get those cancers, that we think that it might be a project we could work on. Yes.
Is there kind of a chart of
when cancer is developed based on your age? I mean, is breast cancer more likely in younger women, or is it get progressively more as people get older?
It's much more when people get older.
Okay.
And the breast cancers that are diagnosed under 40 or premenopausal are more aggressive. So if you get a breast cancer postmenopausal, then it is, there's so many different, that's another thing I meant to, there's so many differences between the types of breast cancer that it's important to make sure that you have a communication with your doctors about what your breast cancer is, because your breast cancer is what you're worried about. And so a postmenopausal breast cancer that's hormone sensitive is different than a premenopausal breast cancer that's hormone negative. And now I can speak to that from experience because I've had both. And and it is, I mean, it is a big difference. So it's just a matter of picking your doctor and talking with them specifically about what's going on and keeping calm so that you can make the decisions that need to be made. But yeah, far more people are diagnosed with breast cancer late in life.
And at that point, if it's pretty late in life, if you don't treat it at all, how rapidly would it, destroy your life versus all the complications of having treatment?
It totally depends on the cancer. So they do, when they do the first biopsy, they check how aggressive it is, and they give it a number. It's called a KI number. And then they do the receptors, which tells you whether it's hormone sensitive to estrogen, progesterone, and or Herceptin. And so that gives you a sense of how easy it is going to be treated and what your timeline is. Both of my cancers, even though they were different, were highly aggressive, meaning when they looked at them under the microscope, they were just like, and my first one doubled in size, and the second one, they both doubled in size before I had surgery. So and so if you have a low KI number, and that's why you sort of have to be really, really, I mean, and of course I was not calm, just for the record, but you really, really have to look at what all of the things that they've chosen to put on that path report. Like my first path report was a page. This last path report was 3 pages. Because they've gotten much more advanced on knowing what that cancer is. And so it's very, very important not to go into it with a preconceived notion of how you're going to be. Like what I did with this was, I knew after another surgery that I had that I wouldn't be able to have surgery, if I ever needed surgery again, that I wouldn't be having it in New Mexico because of the altitude. And so I picked my doctor. Now in anticipation of having any problems. And when I had the problems, I went and counted on the fact that she would know what to do. In other words, I think when you have the diagnosis of anything, it's very difficult to make the choices that you need to make based on, without having other people's experience come in. And I see that with patients all the time. Everybody is a different, every single case is a different case. And every part of your treatment plan should be completely focused on you. But, at the time you're like worried about laundry, you're worried about your shopping list, you need a doctor who's just gonna help you with it.